This is where cariologists live. We live in the world of two inverted right triangles, where we don't want our patients to develop periodontal disease, and we certainly don't want them to develop caries. But realize that these two diseases live at opposite ends of the spectrum. If your patient is prone for periodontal disease, they are not prone for caries, and vice versa, because these two diseases live at opposite ends of an ecological spectrum. Now, if you ask me, well, how do you explain cariology to dental students or to anyone in the oral healthcare community? This is how I would describe it. It's a very complicated chain link fence. We all know it's a multifactorial disease. Notice the yellow star down there. So the yellow star correlates to one of those bacteria over on the left-hand side of your screen. So you're going to want to know, what is the latest and greatest cariogenic bacteria? Well, there are lots of bacteria that cause caries today. Now, you may have been taught in school that's Streptococcus mutans and lactobacillus cause caries. Well, sorry to tell you, no, that's not true. They're involved in the process, but today the prime etiologic agent that I've got my sights on is called Selenomonas sputagina. Selenomonas sputagina is this really cool bacteria. It's one of the first facultative anaerobes that we know is involved in the process. And that facultative anaerobe has a tail. Some might call it a flagella. I call it a tail. But this little bacteria is responsible for increasing the virulence of the biofilm and making it super sticky and porous and allowing it to concentrate those bacterial acids down on the teeth. So Selenomonas sputagina is our new cariogenic organism that everyone is trying to research and learn more about. But we have this whole array of cariogenic bacteria that feed into the process, and they have to live in your mouth for a period of time. And the good commensal organisms like Streptococcus sanguinis and Streptococcus dentisani, those bacteria have to leave your mouth. And this whole thing is driven by poor saliva and diet and hormone. The biofilm is our remineralization agent. If it's a healthy basic biofilm, that biofilm will hold excess calcium and phosphate on the teeth. Our job as clinicians is to enable patients to understand, how do I get that biofilm super saturated with calcium and phosphate? I know most of us have made our entire career about getting the teeth squeaky, squeaky clean. But come on, people, we realize that even the best brusher takes at least 25 minutes of brushing to get their teeth squeaky clean. So we're leaving behind at least a couple cell layers of biofilm and bacteria on our teeth. And if you're leaving behind acidic biofilm, well, you haven't done anything to actually shift the Riemann-Diemann balance. And so that's why what I love about the CPP-ACP molecule that's in GC technology, you have something that actually helps bind calcium and phosphate to these sticky plaque matrices like a cariogenic biofilm, and our sticky products like casein phosphopeptide, that sticky goo that holds calcium phosphate on the teeth, allows calcium phosphate to slowly be released. An inactive lesion does not need your restorative treatment. Now, I realize in school we're taught G.V. Black's fundamental concepts of tooth restoration, and so one of those is to restore form and function, right? I get that. But if a caries lesion is inactive and arrested, it doesn't need you to surgically intervene and cut it off the tooth and replace it with an inferior to material to what biology actually gave the patient in the first place. And so as you're determining the activity of the lesion, the question becomes, how do you do that? Because if you take an explorer and you poke it into a lesion, you might create a cavitation. If you rake that explorer across the surface of the lesion and it feels like you're raking an explorer across a glassy, smooth surface, it's an inactive lesion with an intact surface zone. And if you're trying to remineralize that lesion or you want to get rid of a white spot, well, think about trying to remove that surface zone with something like a quick phosphoric acid etch. But if you don't have that glassy surface and you rake an explorer across it and it sounds like nails on a chalkboard, it sounds rough, please don't poke into it. You don't want to injure this thing. You just want to gently feel the surface of it and get an understanding for how rough is it. And if you find out that it's rough, well, now you have an active lesion there. If you dry off a tooth and you don't see any grooves, you have a healthy tooth. There's no caries affecting that tooth. But if you start seeing grooves, this is an ICDOS code 1 lesion. If it gets a little bit dark and you can see it on a wet tooth, that's an ICDOS code 2 lesion. And these are the types of lesions that we need to realize we can they haven't actually penetrated more than halfway through the enamel, and so we can remineralize these things. And when we remineralize them, they become caries resistant. If you get to an ICDOS code 2 lesion, that's where you see it turning dark and stained, and that's an ICDOS code 2 lesion. I would personally clean that out and seal that up. But when you get to this ICDOS code 3 lesion, when you start to see white demineralization extending away from a darkly stained groove, now we have an active caries lesion that you are justified in actually going into that lesion with a drill down the mineral mother dentin and restore that lesion.